So today I'm going to be talking about supporting a healthy body image, and I wanted to first start with a general overview of the challenge of bodies, body image, eating, disordered eating. Am I muted? I think I'm okay. All right. And so basically, before jumping into diabetes and eating disorders, I wanted to talk just a little bit about eating disorders in general and the challenges that we face. So as women, we face challenges from constant criticism from all angles. The media tells us what we should be, how we should feel, what we should think. Others, friends, families might comment, oh, you look like you've lost weight. Oh, you look great. Oh, you look like you've gained weight. What's going on? Ourselves, where we are criticizing ourselves as we look in the mirror, as we think about how clothes fit. And this really stems from all of the contextual experiences that we get about bodies. And so how do we get information about bodies? We can look to culture and art. And here I'm giving a slide of ideal bodies and what shapes and sizes look like in the 1600s. And you can pretty much pick out how different it is from today. But I think it's important to note equally unattainable for the vast majority of the population. So although people were idealized as larger in size, this was unattainable for people that were not extremely wealthy or did not have access to a lot of high-fat foods, which was very typical of the time. Looking at ideal body images in the 1950s, there were some big changes, and so the athletic, strong male and the thin, hourglass, curvy, vivacious woman were sort of exemplified as the ideal in the 50s, and again, equally unattainable for a large part of the population. Flash forward and we look at our day and age, 2015, and I could have chosen a couple of different segments of the population, and I chose the very overtly hourglass and a lot of fat in certain areas that is very hard to attain for the majority of the population. So Kim Kardashian, Beyonce, and Sofia Vergara as being examples of sort of ideal body images that culture and society speak to us today. So where does that leave us? There's really no perfect body, and all shapes and sizes have a number of combinations and reasons why we got there. Our genetics, our eating habits, our physical activity, our basal metabolic rates, all of these very complicated ways, and yet we're all, sorry as I flash backwards, striving for this, or this, or this in the 1600s. Yet we're all different, and we all have different states and traits. So that definitely leaves us feeling lost and oftentimes feeling like we don't fit in or we're not the normal, and I'm putting up air quotes now as I'm talking. And so one of the campaigns that I really loved, so media can be both good and bad, and it can influence us in a way that feels uplifting and supported or feels overwhelming and leaves us feeling powerless. I wanted to share with you.
Worked for the San Jose Police Department from 1995 to 2011. I showed up to a place I'd never been, and there was a guy with a drafting board.
We couldn't see them, they couldn't see us.
Tell me about your hair. I didn't know what he was doing, but then I could tell after several questions that he was drawing me. Tell me about your chin.
It kind of protrudes a little bit, especially when I smile.
Your jaw. My mom told me I had a big jaw. What would be your most prominent feature?
Kind of have a fat, rounder face.
The older I've gotten, the more freckles I've gotten.
I would say I have a pretty big forehead.
Once I get a sketch, I say thank you very much, and then they leave. I don't see them. All I had been told before the sketch was to get friendly with this other woman, Chloe. Today I'm going to ask you some questions about a person you met earlier, and I'm going to ask you some general questions about their face.
She was thin, so you could see her cheekbones. And her chin, it was a nice, thin chin.
She had nice eyes. They lit up when she spoke.
Cute nose.
She had blue eyes, very nice blue eyes.
So here we go. This is the sketch that you helped me create, and that's a sketch that somebody described of you. So yeah, that's...
She looks closed off and fatter, sadder too. The second one looks more open, friendly, and happy.
I should be more grateful of my natural beauty. It impacts the choices and friends that we make, the jobs we apply for, how we treat our children. It impacts everything. Couldn't be more critical to your happiness.
Do you think you're more beautiful than you say?
Yeah. Yeah.
We spend a lot of time as women analyzing and trying to fix the things that aren't quite right. And we should spend more time appreciating the things that we do like.
I absolutely love that, presented by Dove, and for me, a really good rendition of when the media really helps send a positive image and help support body image. And what I love best about that is not that they asked first for themselves to explain what they look like to the cartoonist, but that then they asked someone else. So instead of having the cartoonist actually sketch them, which would be more reality, they had someone else say to the cartoonist what they saw. And so it's getting at both our own internal body perceptions and the external body perceptions, or how people perceive us and what they see when they see us. And so I thought that that was really powerful and a really strong message of how our own internal monologue is often way off base. Okay, so examining our body image, questions to ask yourself as you're taking this webinar or in your home or daily life. How do I feel about my own body? Do I make negative comments about my body or the bodies of other people? Do I make them out loud? Do I make them to myself? Am I often on a diet, over-exercising, or obsessing about my weight? Do I hide my body from my family and friends? Do I opt out of photographs? Do I not want to be captured? And how do I handle healthy eating and activity as it relates to my body? And often, again, our own self-perceptions are warped or more negative than what other people perceive of us. So when you add on diabetes, so that's just the general overview of how there are multiple influences and contextual experiences about women and bodies in general. I mean, everyone in bodies, but particularly women in bodies. And then you add on diabetes. And with diabetes, there's a hyper-focus on a lot of things that make body and body images particularly difficult. So often at diagnosis of type 1 at least, there's a large, quick weight loss, sometimes seen at diagnosis for type 2 as well, depending on the numbers. And usually this is followed by some rapid weight gain when put on a regimen of insulin and or other oral agents that will help with the insulin, with the glycemic control. And so when you see this large weight loss and then large weight gain, it becomes really linked in your mind. And then on top of that, you're asked by the medical team to constantly scrutinize food choices and look at carbohydrates, count carbohydrates, be hyper-vigilant and hyper-focused on foods, and trying to limit the high-carb foods in your diet. And then there's this overlay of disappointment in your body. So oftentimes patients describe feeling like their body is broken. I had a young girl who was struggling with type 1 diabetes and an eating disorder and stated, you know, it wasn't about being thin for her. It was about rebelling against her body that stopped working. And so when there was this sense that her body gave up on her, she felt like she wanted to give up on her body, and in this way withheld insulin to kind of get revenge. Often there's feeling like the body is just a vessel for medications or has been over-medicalized by the health system, and feeling like, you know, what is the point? What's the use of this? All I do is pump medications inside of myself. Or the body is just to be poked and prodded. And if you even look up pictures, I spent a lot of time Googling images of diabetes or diabetes regimen or diabetes care. The images are very negative, and they've really parsed out components of the body. So I didn't talk about that in the media, for general media, but when we start to dissect and see images of just a hand or just a foot or just our stomach or these different pieces of your body, you become less whole person oriented, and you become less focused on your entire health and overall well-being and more focused on these very specific areas. And that's been linked to eating disorders in the literature as well. So with diabetes, you have this added focus on very specific things that the body needs to do, and then it's kind of an over-focus that becomes difficult when we're talking about eating disorders. And all of these are sort of, instead of looking at the body as a strong and healthy vessel, regardless of the things that show up on a daily basis. So instead of looking at it from a disease model, where it's like diabetes is a disease, we look at it as like chronically health model, or living with a chronic illness, but looking at yourself as a strong and healthy person that's able to incorporate diabetes into your life instead of your life being surrounded by diabetes. I love this picture of the yoga poses. So the definitions of an eating disorder, and I just wanted to spend a little bit of time on this because there's some big distinctions between an eating disorder and disordered eating. An eating disorder is sort of severe abnormal eating habits that may involve either not eating enough or excessively eating or restricting calories to the detriment of a person's health. So this also includes compensatory behaviors, which is just a fancy way of saying things that you do to get rid of food, like taking laxatives, omitting insulin, over-exercising, purging, so throwing up, any of the things done to get calories out. And it also includes the overeating or not eating components. And there are two major categories, the anorexia nervosa and the bulimia nervosa. And so really, honestly, only 1 to 2% of the entire general population fall into one of these two categories. I mean, it's like 1 to 4%, depending on the study that you look at. But women with diabetes actually are much higher than that, maybe 10-fold higher than that, and ranges. I've seen studies that talk about anorexia nervosa and type 1 diabetes being linked like anywhere between 5 and like 70% in one really extreme study, which I think is the true normal is probably closer to maybe 10 or 11%, which is still a very large number compared to the general population. And that's because of those instances of having to be hyper-focused and overly reliant on parsing out our body in this way. And so disordered eating is not an eating disorder, it's different, and refers to a whole big range of irregular eating behaviors that don't necessarily meet the qualifications for a diagnosis or any sort of specific eating disorder, but are harmful to your life. So this could be kind of under-bolusing in order to keep your sugars a little bit high, in order to keep your weight down, or it could be skipping meals or eating irregularly. For some people, there's like a craze for juice fasts or juice cleanses where they're going to extreme measures of cutting from a 2,500 a day calorie diet to a 800 calorie a day diet and dropping excessive amounts of weight in a quick amount of time. And so while those might not have all of the different characteristics that would be diagnosable for an eating disorder, they still are a disordered pattern of eating behaviors. And so being mindful of this, sort of thinking out how this may or may not pertain to you or people that you know in your life, knowing that there's vast larger amounts of people that have disordered eating than there are eating disorders. And so more warning signs with diabetes specifically include unexplained weight loss, which is akin and similar to what we see when someone with type 1 diabetes is diagnosed. You have a rapid weight loss, and that's usually because of either ketoacidosis or really high blood sugars, and perhaps not ketonic, but not being able to digest and ingest the calories in food that's eaten, and instead having your body expel them, and so then losing weight. Extreme concerns about weight and your body shape, some unexplained elevations in A1C or blood sugars, secrecy usually about blood sugars or seeing someone's meter, your meter, or insulin or eating patterns, and then blood sugars that don't match an A1C, so maybe having a meter readout that is not, like maybe numbers kind of all over the place, and then having an A1C that's kind of in perfect range. And then some major changes in eating patterns or exercise behaviors, and then missing monthly menstrual periods. And so often, though, what we see is that women don't speak out. I mean, men as well, but people that are exhibiting eating disorders or disordered eating and have diabetes are often suffering in silence. And this is usually because of the stigma associated with these behaviors. Sometimes it's because not wanting to be caught out, but sometimes it's because healthcare providers do a poor job of asking or figuring out, is this something that's relevant? I know I've seen a lot of women, even at conferences, at Diabetes Sisters conferences, that raise their hand and say, this is the first time I'm saying this, but I have been omitting insulin for years. And other women that raise their hand and say, this is the first time I'm saying this, but I binge often and it feels out of control. And these are things that often the medical teams either miss or just don't ask about because they're not sure how to handle it or what to do. And so, one of the major goals of Diabetes Sisters and of my own practice is to break down these barriers and to reduce the stigma associated with these and talk about this like we would talk about anything else that people are suffering and struggling with. So what to do if you or someone who has experienced some of these distressing symptoms is really don't be afraid to ask. Don't be afraid to ask someone in Diabetes Sisters. Don't be afraid to reach out and ask a medical provider. Don't be afraid to ask a therapist, really, and say, I'm struggling with this and I am not sure what to do. And this is something that's been either at the back of my mind or at the front of my mind for quite a while, or has just recently cropped up for me. But don't be afraid to ask. And then shifting focus away from weight, and that kind of plays into my next slide where I talk about specific modalities or types of therapies that help. But really, in the type of therapy that I provide, the focus is on reorienting to the things that matter to you in life. And so while concern about weight or concern about body is still there, deciding what are my values, and what are my goals, and what do I want out of life, and then figuring out if the different negative behaviors help you reach those goals and values, or if they detract from your life and start taking away the meaning and the vitality in your life. And so shifting focus away from weight and shifting focus onto other things like, things that the body can do. That might be physical things, that might be meaningful relationships, but other things that may improve health but not be focused specifically on weight. Obviously bringing up your concerns to your medical team if that's possible. And then seeking mental and nutrition counseling. So mental health is really important, but nutrition counseling is also important. And so the type of help to seek, a lot of people have come to me and sort of said, I'd love to get help on this, but I just don't know where to start. I always say it's really, really best if it's multidisciplinary. Someone should not be caring for someone else alone that's experiencing these symptoms. And, finding team members that understand diabetes is also equally important. So a multidisciplinary team, like when I see a private patient that is struggling with an eating disorder and diabetes, I have their endo on speed dial. I'm their therapist, and I usually see them about 2 times a week. We have a nutritionist also working bi-weekly and collaborating, and we have weekly check-ins, and we have sort of monthly updates as well for bigger goals and the bigger picture. And then I make sure that there is no miscommunication between the different team members, so I kind of act as a liaison. And so when things are sort of beyond this outpatient model, or just the outpatient model is not going to work for someone, then we do usually recommend inpatient stays in order to get things back up to speed. So the different types of therapies for eating disorders and diabetes, or disordered eating and diabetes, I think that have not proof, we say evidence-based, is cognitive behavioral therapists, acceptance and commitment therapy called ACT, and then usually pharmacological therapy in adjunct, so having some medication or a psychiatrist also as a part of the team can be really helpful depending on the nature of what's going on. So the goals of therapy, the first and primary goal is medical stabilization, and so in severe cases, like I noted, we may need to have patients hospitalized in order to take over control of both diabetes and other mental health concerns, but then gradually shift control back to the person as they're being re-stabilized. And so the real goals are obviously to address the underlying causes of the disordered eating. And so, you know, if that one teen that I mentioned who really was rebelling against her body and feeling like she was rebelling against her parents, if that was kind of the driving force and it wasn't wanting to be thin, it would be a different treatment than it would be for someone that really is wanting to be thin or has been told by the treatment team with type 2 diabetes that they need to lose a certain number of pounds and has become single-mindedly focused on that. You know, those would be different treatments. But we really do want to normalize the use of insulin as just an everyday thing again, normalize blood glucose levels and weight, because eventually we want to avoid acute and chronic complications of the insulin deficiency and hyperglycemia. And so looking towards sustainable recovery and looking towards sort of the outpatient model, after initial interruption of symptoms, which may be inpatient and or maybe just a more intensified outpatient program, then we're sort of shifting the focus, like I said earlier, back to identifying personal values and life priorities and seeing where health, fitness, weight loss, all of these things fit in. Is it in the service of something that you're hoping to get out of your life? Does it make your life more meaningful and vital, or does it take away from the things that make your life more meaningful and vital? And it's really important to have solid aftercare plan if patients are hospitalized or more intensified, because we see really high rates of relapse. And so it becomes kind of a recurring thing. And so you really want to bolster professional support and accountability, have a team leader. I'm usually the team leader for my patients, and I'm the one that reins everybody in because people have busy schedules, including the providers. Having supportive family and other loved ones surrounding. And, you know, I have one patient actually who I've really encouraged to move back home, even though that wasn't preferable. That was the best way to get support and the best way to be sure that that we can prevent relapse. And then personal engagement with meaningful activities in one's life. And so finding ways to connect and to feel engaged in your life, and then of course pursuing your personal interests. So again, shifting focus away from the weight loss and onto life values is really important. And that's all I have prepared, but I wanted to make sure with the 5 minutes that we had left to leave room for questions.
Unmuted.
So, Deanna, no one has sent any questions, but I wanted to reiterate that if anyone does have any questions or they have any personal questions that they would like to ask Dr. Naranjo, her email is on your screen, dnaranjo@stanford.edu, or similarly, you can send me an email at anna@diabetessisters.org, and I can forward it to Dr. Naranjo. I wanted to thank you. Before we signed off, I wanted to thank everyone for registering and participating. I want to thank Dr. Naranjo for providing us some more information about body image and living with diabetes. we will be forwarding a rating sheet from today's webinar. It helps Dr. Naranjo to better understand the needs of the audiences. So you will be receiving that. It's a Word document. Please fill it out and return it to me. I will compile it and forward it back to Dr. Naranjo. It will be completely anonymous, so please be honest and share your thoughts. I also wanted to thank you again and thank you for participating. We had over 59 people registered for today's webinar, which is being recorded and can be further accessed on our website tomorrow morning. And we've taken all of the registrants, we've entered them into a drawing to win a copy of Susan Wiener's book, The Complete Diabetes Organizer. We randomly selected a winner, and that is Valerie Davis. Congratulations, Valerie. We'll be contacting you to send out your prize in the mail. We hope to see you at our next webinar. It is scheduled for November 18th. It will be led by Jennifer Smith, who works with Gary Shiner at Integrated Diabetes Services, and the topic will be tips for making diabetes easier. Thank you again, and have a great afternoon.
Have a great afternoon, everyone.
Bye.